we're very happy and honored today to have Kelly Baker with us, and she'll be introducing her own seminar, and wants people to please jump in if you have questions or comments, but we're also leaving time, as we usually do with our guest faculty seminars or any of our seminars on research. We leave time at the end to actually discuss the research and ask questions or make comments. So, but before, I'd like to tell you a little bit about Dr. Baker. She's an assistant professor in the Department of Occupational Environmental Health at University of Iowa College of Public Health, with a secondary appointment in the Department of Epidemiology. Her research aims to identify socio-developmental interventions that prevent adverse birth outcomes, enteric infections, and malnutrition in young children that live in underdeveloped communities. Her studies you'll hear about, but they include a Fogarty-funded PATHOME study in urban Kenya, and other studies in clinical environmental microbiology, human behavior, zoonotic vectors, food safety, and geography. So really quite a diverse global health researcher that's going to join us. She's a core faculty member of the National Institutes of Health and National Science Foundation funded programs supporting education and training opportunities for underrepresented minorities in science. Nationally, she serves on the National Academies of Medicine's Board of Global Health and the American Society of Tropical Medicine and Health's Global Health Committee. She received her PhD in molecular microbiology and immunology from the University of Maryland, Baltimore. And I could go on, but I won't, because we want to have the seminar. And so, but you can't get away from having a long introduction for Kelly. So Kelly, thank you so much for joining us, and the floor is yours if we're ready.
All right. Yeah, thank you for having me. Let me put my slides up. Right. So I'm gonna talk a bit today about the One Health sort of approach to some of the research we're doing on transmission of enteric pathogens and malnutrition in children in disease endemic areas, mostly in sub-Saharan Africa. But as, oops, this is not forwarding. There we go. My research program is really focused on ensuring that children have a healthy start on in life by starting off at a healthy birth weight, born at the appropriate, sort of after 37 gestational weeks, but also after that sort of healthy start at birth, that they are able to, follow the ideal growth trajectories for children in the first 5 years of life. So while I'm going to focus a bit on the sort of studies on enteric pathogen transmission, especially through food, some of the other research that I'm not going to touch on here, but I'm happy to answer questions about later, includes some of the work that we're doing in India on pregnancy outcomes in women and the role of social and environmental conditions on birth outcomes, development of different types of exposure assessment methods, and then some work locally here in Iowa examining the role of animal confinement facilities on groundwater quality. So I got my start in global health as a postdoc on the Global Enteric Multi-Center Study. It was one of the largest studies funded by the Gates Foundation on causes of enteric disease. It was a 7-country study, which you can see here from the different sort of countries listed in different colors. And one of the things that really captivated me about the GEM study, and that focused my sort of attention on the first 12 to 18 months of life for child health, was that we were seeing in multiple different countries in the GEM study that this 0 to 12, 0 to 18 month time frame is really when we see these catalytic changes in population prevalence of enteric pathogens like Shigella and Shiga toxin expressing E. coli, right? So we have these big changes across the population in how many children had these pathogens in their guts. One of the other things that I noted in the GEM study that has influenced my thinking is that a lot of these infections are emerging prior to 6 months age. So in multiple different countries in GEMS, we saw pathogens like Shiga toxin expressing E. coli, among others, having high prevalence rates in children between 0 and 6 months of age. In our sort of site in Kenya, where a lot of the research I'm going to present is based, and we work in peri-urban and urban low-income neighborhoods in Kisumu and Nairobi. This is some data that I'm going to talk a little bit more about in a few slides from two studies that are sister studies, the Safe Start study and the Market to Mouth study. Safe Start is a cluster randomized clinical control trial of a food hygiene behavior change intervention. And we enrolled children at 6 months of age into this study prior to allocating them to intervention or control arms. And at the point that we enrolled children into the study, we collected feces samples and tested them for a wide scope of enteric pathogens. And so the big takeaway from this slide is that by 6 months of age in these neighborhoods in Kenya, we have a huge variety of enteric pathogens that are being detected across this cohort of children, including many co-infections, which I'm not showing in this graph. And that a lot of these pathogen detections are occurring in children that aren't necessarily exhibiting diarrhea, right? So dark blue is reflecting the proportion of children who are positive for a pathogen that also had diarrhea symptoms. Asymptomatic infections are still a bit of a topic under discussion, although there is evidence suggesting that they can have long-term health impacts for children as well. But no matter what, all of these pathogen detections do confirm one thing, and that is that children are exposed, to very high levels of pathogens by 6 months of age. This is data from that same study demonstrating the dynamic component of enteric pathogen transmission. So we followed children for 3 months in that study and then tested their stools at 9 months of age for the same set of pathogens. And this was so that we could evaluate whether the intervention was reducing enteric pathogen infections. And what we observed between 6 and 9 months of age of following these children, we observed that there were a small number of pathogens, including rotavirus, that were lower in prevalence at the point of matriculation out of the study at 9 months. But for the most part, children over that 3-month time period were acquiring a great deal of pathogens, right? So this percentage represents the increase in proportion of children between 6 and 9 months of age that were being infected with these pathogens, right? So intervening in this time window, as well as prior to 6 months of age, is really critical for ensuring that children can either altogether not have enteric infections or at least push them off into later childhood when their bodies are bigger and stronger and immunologically competent for helping fight off some of these infections. So where are all of these infections coming from? The enteric disease transmission system is very complex, not just in terms of the number of different viruses, bacteria, and parasites that can infect children, but also in hosts. So many animals, including domestic animals used for household food production and companionship and security, can carry the same pathogens. But also these pathogens can be trafficked through multiple different types of environments. So if you have animal feces or human feces that's left out in the open, that feces can transmit the pathogens in it through drinking water supplies, the lakes and rivers that people wash their clothes in or bathe in, fingers, flies can land on feces and get it into their legs, children's toys and the floors of homes, right? And the pathogens can also be transmitted through food. All of these different types of environmental fomites do have contact with foods and ultimately wind up in the mouth of a new child. Now, a lot of the thinking about how you prevent transmission for enteric disease is encapsulated in sort of these benchmarks here, right? So we have sanitation, clean water supply, and in green here, hygiene. This is from a 1950s diagram called the F diagram that was really used to centralize policy thinking about which interventions might have the greatest impact on disease transmission. Some of the other thinking, that has influenced global policy about enteric disease transmission in the last, century also comes from a lot of historical, demographic, and epidemiological transition data. So, for example, this is a graph from health record data from Philadelphia at the turn of the 19th to 20th centuries. And specifically, what we're looking at is typhoid deaths. So prior to the 20th century, United States cities had equally high levels of typhoid deaths that we see in many low-income disease endemic regions of the world today. And right around the sort of 1900 to 1920 timeframe is when there was an explosion in development of municipal water supplies in cities, starting on the East Coast and then gradually making their way westward. And these water supplies, initially they were not necessarily treated. They were really just about getting water from point A to point B. But some, right around 1910 to 1915, a lot of those municipal supply systems started implementing filtration and then chlorination systems on the water supply. Wastewater treatment lagged by a decade or two. It came about, more here in the 1920s. But a lot of the sort of impact of water on early health patterns in today's high-income countries has been derived from these transitions and through studies attempting to estimate how water and wastewater supply impacted these transitions. If we look at more recent data from the Millennium Development Goal era tracking of households with access to improved water sources and access to latrines of improved design, we've got about 25 years of data, now a little bit more, right? 5 more years. But if we look over the 1990 to 2015 timeframe at progress for developing improved water infrastructure and improved sanitation infrastructure, we see that in urban areas, there's been a little bit of gain over 25 years in household infrastructure quality, but we see big gains in rural areas. And so to a great extent, the MDG era represented a big period of success in addressing these sort of deficits in safe water access and latrine usage in populations. So this raises the question of whether, if we look at health data over this same time frame, do we see sort of commensurate and inversely correlated changes in enteric disease transmission? And the answer to that is not so much. In 1990, there were an estimated 2.3 billion cases of diarrhea per year. The most recent estimates for 2015, 2017 put diarrhea cases per year at around 1.6 to 1.7 billion. So we've really only seen a 1% drop in cases per year in spite of these really big changes in household water and sanitation quality. This minimal impact for investing in just water and sanitation infrastructure is reinforced by several recent, very well-powered, large, multi-country clinical trials, randomized controlled trials that had multiple arms, including arms where they improved household drinking water sources, built latrines of improved design, promoted hand washing with soap at critical times, all 3 of these strategies together, and then also for comparison, micronutrient supplementation. There are more studies than this at this point, but this is just a useful graph for demonstrating that in 3 different countries, 3 different sort of studies, for interventions where they had really high intervention fidelity and high intervention compliance in use of the latrines or improved water sources or hand washing, they didn't have a great deal of impact on environmental hygiene. So here in yellow, it is suggesting that there was mixed evidence of reductions in fecal contamination in the household environments that should have benefited from these water sanitation and hygiene interventions. Similarly, with diarrhea, there was a mix in outcomes from these studies, ranging from no effect on diarrhea from neither one arm nor the combined wash sort of intervention approach, with a couple of exceptions in Bangladesh, and similarly no effect on linear growth of children. Right? So stunting is a great indicator of reduction in Reduction in stunting is a great indicator of reduction in chronic exposure. What's not shown here is that these studies also invested a lot in diagnostic platforms, testing for a lot of the pathogens that we know cause enteric disease in children. And similarly, they found, depends on the study, but they found no effect or maybe some very limited effects on some pathogens. So the sort of takeaway from this historical data, as well as sort of recent research study evidence, is that while drinking water and sanitation infrastructure are necessary for helping reduce enteric disease, they don't appear to be sufficient and they're just on by themselves for causing sort of epidemiological transitions in enteric disease. So if you're a policymaker in a country that's struggling to replicate those transitions from communicable to non-communicable diseases, it prompts you to rethink, well, what should my disease priorities be? Where should I be investing instead in order to achieve now sustainable development goals for enteric disease? Some of the pieces of this transmission diagram that have received less funding and attention over the past century include management of animal feces. For obvious reasons, chickens and goats and dogs are not using latrines. And so a lot of animal feces, especially when people are cohabitating with their domestic animals, can get also into the environment and be trafficked through the environment to the mouths of vulnerable children. But animals also play a really important role in food safety, food quality, both in the home as well as through the food supply chain. So the first set of studies that I'm going to talk to you about, I'm going to go back to the Safe Start and market to mouth studies and just present a couple of the takeaways from that. But it really focuses on exploring the role of foodborne, of food systems versus households in transmission of foodborne pathogens. So as I mentioned, Safe Start and market to mouth are two integrated studies that together were designed to evaluate the impact of milk product safety for infant feeding versus household food hygiene behavior change approaches at preventing contamination of infant food and preventing enteric infections in infants. And up here in the left and right are some of the references where you can find more details on these studies. These studies were funded both by CGIAR and the DFID, the International Development Arm of the UK government. So we focused on food, not only because it was a under-researched area in child health, but also because the World Health Organization really identified this as a huge gap. They convened a foodborne disease burden epidemiology research group between 2007 and 2015, and they produced this beautiful report estimating global burden of disease from food. Focusing in on the microbial pieces of this study, some of the takeaway messages were that data on the role of food, especially for children under 5, is really limited. This is complicated by many nations not having food safety and surveillance systems, little research on food hygiene behaviors in the household, and especially a lack of studies examining food supply versus household contributions to food safety. One thing they did conclude is that many of the sort of leading foodborne pathogens that are of importance, that do cause a large number of deaths and disability adjusted life years, are ones that have been identified by these clinical trials like the GEM study. So non-typhoidal Salmonella enterica and intrapathogen E. coli in particular cause somewhere between 160 and 320,000 deaths, mostly in African children. All right, so it's a large burden. The studies were focused in Kisumu County, Kenya. So Kenya does have high diarrheal disease rates, high malnutrition rates, but even within Kenya, Kisumu County is a particularly high burden area. The under 5 mortality rate is about 26, 27 cases per 1,000 above the national average. Infant mortality is also about 50% higher. And many children have not received all of their under 5 basic vaccines. So we started off, prior to the Safe Start Market to Mouth study, we implemented some formative research because we didn't have a lot to go on in terms of what happens to food, what are caregivers buying for their children, when they bring it into the home, what are they doing with it, and where might we target the Safe Start behavioral intervention messages to try to prevent transmission of pathogens through this food chain. And so one of the things that we uncovered was that there were lots of different action points through this hazard assessment critical control point approach. We found lots of action points where household behavior change interventions needed to sort of improve knowledge and practices among caregivers. And so this was the sort of basis for a lot of the design of the Safe Start intervention. But one of the other things that we observed is a high reliance in this peri-urban population on prepackaged milk. So on this picture up on the left is what's called fresh packed milk. It's pasteurized milk, just like what we would buy in our store here, but typically sold in smaller bulk quantities. Here on the right is what we call ultra high temperature treated milk, UHT milk. So it is treated to a greater extent than pasteurized milk. And this is done so that it can be stored at room temperature prior to opening. So it has a far greater spread or scope as far as a consumer base goes into areas where refrigeration is not necessarily available or the norm. And so what we were observing with a lot of these these pre-packed milk products is that they were not being prepared like other foods in the home, like porridge, for example. Caregivers would buy these milks and then add them to porridge after cooking to cool it down quickly so that they could move on with their day. They could feed the child and get on with all of the other array of domestic responsibilities that they had. And we also observed that a lot of these foods were fed to children directly without any cooking. So cooking was not the norm with these. Normally pasteurization is considered a very effective means for rendering milk safe to drink. As I mentioned, ultra high temperature treated milk is even safer than standard pasteurization. However, it is acknowledged in the food safety industry that pasteurization is not sterilization. The food safety guidelines used in Kenya are laid out in hygienic practice codes. However, there is not a national system. Testing is mostly voluntary. So a lot of what we know about milk safety in Kenya is pretty limited and probably biased. And foodborne pathogens are definitely not monitored. Here on the right, one of the things that I want to point out is that even among pasteurized milk, there is an acceptable level of total coliform count contamination that is considered okay for milk to remain on the market, but no level of E. coli or Mycobacterium tuberculosis is considered safe. So there are slightly different standards for pasteurized and raw. And the reason raw has higher tolerance standards is because it is assumed that people will cook this before consuming it. Right, so as we launched into the Safe Start study with this prior formative research evidence, one of the things that we were worried about was, well, our intervention is targeting household food hygiene behavior change, right? So we're promoting boiling all foods, washing hands before cooking and feeding children, feeding children out of designated child-only dishes and utensils, and not storing food in containers with lids on it. But given what we saw about this reliance on prepackaged milk, that had this potential for derailing our intervention, right? If these foods were not being treated according to the behavioral sort of recommendations that we were providing. So we received funding to nest the market to mouth study into this process. So in blue, what you see is Safe Start. As a reminder back to the sort of slides that I showed you early on, we enrolled children at 6 months, collected a stool sample that we tested for enteric viruses, bacteria, and parasites, conducted a survey, allocated them to intervention or control arms. And then at 9 months after the intervention lasted 3 months, at 9 months when households were matriculating out of the study, we took another stool sample, tested for the same pathogens, repeated a survey. Market to mouth steps in here at 8 months. So what we did was we sent our team back into the home at 8 months, both for intervention and control arms, and observed caregivers as they went out and procured ingredients. We focused on milk because it was so common. We went with them to the market to procure the ingredients that they were going to use to cook food for their children, and noted things at the point of sale like cost and expiration dates and storage conditions. We collected our own identical sample of milk in particular that was being bought by the caregiver. And then back in the home, we observed caregivers preparing this food. And at the point of feeding, we took an infant food sample. And in this paired set of samples, we performed identical qPCR TACMan array tests that we were using on stool samples for children at enrollment and matriculation from the study, as well as some culture-based assays. Safe Start's results are still pending. So what I'm going to do is just describe some of the takeaways from the market to mouth piece of this. This is just a quick summary on our microbial methods. It's quantitative food microbial methods. We cultured Salmonella enterica, pathogenic E. coli, and Shigella species, including a sub-study on antimicrobial resistance in Salmonella. And then on the quantitative PCR side, we looked for many of the same bacteria, Salmonella, E. coli, et cetera, as well as viruses and parasites that we were looking for in child feces, and human and bovine microbial source tracking markers. All right, so this is takeaway point number 1 from market to mouth, which is that when we looked at our microbial data in infant food, a lot of what we found reinforced common knowledge about how the efficacy of pasteurization. So here in light gray, we have our ultra high temperature treated milk. And when we look across bacteria, Enterobacter aerogenes, Salmonella, Shigella sonnei, and EHEC, we see much lower levels of contamination in milk at the point of purchase compared to raw milk here in the darker color, right? And pasteurization is somewhere in between. So not surprisingly, pasteurization can make milk safe at the point of purchase. Similarly, when we looked at the number of species that we were co-isolating out of these milk samples, we saw a very similar trend where diversity was pretty low in UHT milk and much higher in our raw milk. All right, so this raised the question of whether or not purchase of UHT and fresh pasteurized milk meant that children that were being fed infant food made with these milks, were they consuming less contamination than children that were being fed milk made with foods made with raw milk? And the answer is no. When we look overall at all bacteria, as well as at the specific types of bacteria that we were isolating out of infant food at the point of consumption, we found no difference between the detection of these of different types of bacteria across the sort of categories of milk products used to make them. And same thing here with diversity, we see very similar levels of species isolation, regardless of whether the infant food was made with UHT fresh pasteurized or unpacked. So we wanted to know then whether contamination in the milk product itself, right? So we did have, as a reminder here, we do have some milk products, pasteurized and UHT, where we did isolate Salmonella enterica and Shigella and Enterobacter. So we wanted to know whether or not it was children that were eating foods made with these contaminated but pasteurized sources that were sort of contributing to some of this lack of difference at the point of consumption. So we estimated the odds that contamination in milk at the point of purchase was associated with increased detection of contamination by the same type of bacteria at the point of consumption. And the answer to this one was yes, we do see a significant increase in odds in contamination of infant foods if the milk source used to make it was unsafe. And in particular, we noted this trend for ultra high temperature treated and fresh pasteurized consumers. And so, some of the takeaway points for us from these studies was that, as the world becomes more urban, as it becomes more reliant on prepackaged food the importance of food systems in human health and foodborne disease is also going to increase in importance. And so we really need to be thinking about joint interventions, tackling supply chain and household food hygiene behavior change. Nonetheless, from thinking about intervention messaging, we feel pretty confident that promoting pasteurized milk at the point of purchase is definitely a good strategy. It should be promoted. But again, we did see in 2% of our UHT and pasteurized milks detection of Salmonella and Shigella. And so we need more hazard assessment critical control point studies that can identify where system failure is occurring. This is important because of the large consumer base, right? When these suppliers are preparing food and distributing it, there are tens to hundreds of thousands of people that are potentially consuming these products. While the food system is important, most of the contamination emerged in the household environment. And so, one of the things that we want to do going forward, and this is we have a trial grant pending with NIH for a phase 2 here, is to focus a lot on household behavior messages, and specifically making sure that we're well targeting management of packaged foods. And we also want to start earlier. Remember that at 6 months, it was almost too late, right? We already had really high levels of pathogen detection. So we think that these interventions need to be intervening at least by 3 months, if not starting shortly after birth. One of the things that we're particularly worried about here with these food products is that the perception of milk safety is causing behaviors in the household that increase the risk of contamination. So if you think about UHT, it's branded as long life milk. In some of our qualitative follow-up work with caregivers, we have documented that caregivers think that long life on it means the milk can be stored for longer periods of time after opening, right? So we think that the milk is being stored for too long. So I'm going to shift gears to a different set of studies called social microbes. Again, exploring poorly researched areas of enteric disease transmission. Social microbes is really focused on quantifying exposure risk for children in neighborhoods, both in Kenya as well as in Haiti, from public areas. In these dense urban settings where households are small in size, many of them don't have their own private yards. Children, including infants, spend a great deal of time in the neighborhood residential space. And if that neighborhood has low levels of sanitation coverage and high levels of open defecation and free roaming animals, then these areas may be even more important in transmission of pathogens to children than the domestic environment that has been historically targeted by Millennium Development Goal policy and Sustainable Development Goal policy. So one of our first things that we had to do was develop new methods for looking at pathogenic diversity across these neighborhoods. We adapted the same qPCR high throughput microfluidic TACMAN array cards that have been used for diagnostics of children to soil and surface waters in the same neighborhoods where we've been researching. What we found was that just in simple cross-sectional assessments of neighborhood environments, we found lots of the same pathogens that we have observed in the guts of children, both in soil as well as in surface water. And a lot of our soil and surface waters, we found multiple pathogens at the same point in time, right? So if a child consumed soil or surface water, they could ingest two or more different pathogens at the same point in time. So environmental contamination is not the same thing as exposure. So one of the other things that we had to do is develop a quantitative behavioral tool for measuring how often children are in these public environments, how often they're touching things like soil and trash and other objects, and how often do they follow those child environment contact events by sticking their hands in their mouth and completing the sort of exposure pathway. So we adapted a software tool that was developed by Stanford University for monitoring child-child and child environment interactions in Haiti and in Kenya. It's a tablet-based tool which greatly expedites the efficiency for enumerators in recording these behaviors. And some of the data that we collected out of this quantitative approach allowed us to look at factors like, for example, how many contacts do children have with soil or trash? And how does time spent playing in an outdoor environment like this, how does that influence the relative risk for touching soil and trash? And tied to that, how often, how does time outdoors in the environment impact the child's probability of putting a hand in a mouth after having contact with the contaminated soils and surface waters? Following that, we collaborated with Dan Sewell, who's a biostatistician here at the university, and my co-PI on the next study that I'm going to talk about, to integrate the environmental microbiology data and quantitative behavioral data into a new Bayesian exposure assessment model that predicts not only Salmonella enterica exposure, yes, no, and dose, but also allowed us to estimate the probability of multi-pathogen exposure. Right. And this is really important for matching against just the sheer diversity of pathogens that we're seeing in the environment. So through the development of this exposure model, we're able to do things like compare soil versus surface water exposure pathways and look at the probability that contact with neighborhood soil or neighborhood surface water, puddles, rivers, et cetera, was going to result in a child ingesting more than one type of enteric pathogen. So just for example, using these risk maps, with soil, we see that, that there is sort of a cap on probability of ingesting multiple pathogens from contact with soil, but with surface water, there really is no safe level of contact for a child. Just 2 or 3 sort of exposure events could result in ingestion of 4, 5, 6 types of enteric pathogens. Right. So these 2 studies were really useful for addressing gaps in knowledge about where else outside of drinking water and household sanitation and hand washing might pathogens be coming from. One of the things that we couldn't take from those studies is the capacity to examine in the relative importance of, for example, food, exposure from food versus exposure from play outside your doorstep. And this is really, important when we talk about this concept of prioritizing or reprioritizing how going forward nations and NGOs and other types of agencies invest in enteric disease prevention interventions. So that led us to a study called PATHOME, which is funded by the National Institute of Health. The goal of the PATHOME study was to do a comprehensive assessment of exposure for children across as many of these pathways as possible. Now, you can imagine that if you wanted to do an intervention, right, if you were going to try to design a multi-armed trial examining how changes across all of these different types of household environmental conditions was going to influence child health, it would be logistically and financially unfeasible. It would be impossible to conduct. So it really required a different approach for examining, the sort of benefits from investing in different types of interventions. PATHOME is based on this concept that epidemiological transitions, we don't have to look back over a century to understand epidemiological transitions. They're happening in real time in urban cities all over the world. There are rapidly growing middle classes in Kenya and in Tanzania and in Bangladesh. And with a very careful study design that samples across the spectrum from poverty to middle class office worker lifestyles, that we can design a study that allows us to identify what tipping points, what triggers the tipping point in health for people living in this type of environment versus this type of environment. So the goal of the PATHOME study, this is funded through the Evolution and Ecology of Infectious Disease mechanism. The goal is to construct a virtual laboratory that will allow us to predict how societal development causes a collapse in enteric disease transmission in high burden settings. So, again, this is really designed to address that gap that in a sort of modeling capacity for natural evolutionary processes that unfold that can't really be tested well through randomized controlled trials. So in this tool, if you have sufficient data about household environments, neighborhood environments, social interactions, spatial elements, then you can predict the impact, for example, of paving floors in households versus continuing with improving drinking water sources. And so this is just another way of sort of thinking about this perspective, going back to our map of Philadelphia's epidemiological transition for typhoid. If we were to sample children in Philadelphia here versus here, or the environments that children live in here versus here, what we theorize with PATHOME is that Philadelphia pre-1900 would have extreme enteric pathogen diversity across the environment, just like we see in Kenya and Haiti. On the flip side of this, post sort of transition or early transition, we would find far less microbial diversity. Now, diversity is a really important piece here because, let's say, for example, we chose rotavirus to monitor how disease trends were changing over time. We've only recently made a lot of progress at eliminating rotavirus through the rotavirus vaccines. And we wouldn't have detected a lot of difference sampling from Philadelphians here versus here in terms of infections and environmental hygiene. But if we look at the sort of co-transmission of pathogens, that this is really the best indicator for finding the tipping points that cause disease transmission to collapse. So PATHOME is based on what I call a pathomicrobial ecology approach, meaning that we are borrowing the same concepts used in microbial ecology that focus on community richness and diversity for pattern recognition, but we're doing so through a public health lens where we're looking at the pathogens that cause this complex infectious disease. So we define the enteric pathome as the microbial communities of virus, bacteria, and protozoan pathogens that are transmitted by human and animal feces through the environment. So we're just getting started with this study, or we've been at it for about a year. So I'm not going to be able to present any results, but I'm going to just really quickly go over our study design. We are sampling out of low and middle class neighborhoods in Kisumu and Kenya. We are spanning a year in each environment so that we can collect climate data and understand how climate might influence our trends. It's a 14-day prospective cohort study of 248 children between 0 and 12 months of age and their caregivers, with a lot of attention to equally sampling across the 0 to 12 spectrum. And our outcome is the probability that an infant is exposed to any pathogen or a complex range of pathogens. So we enroll children in on day 1 and follow them for 14 days. And throughout this process, we collect 5 infant stool samples. We do a survey at enrollment. And following this baseline stool sample, we do an in-depth exposure assessment that includes collecting animal feces, environmental samples, structured observation of child environment and child-person interactions, and geotracking of children and the animals that they live with. We're also collecting weight and height information and self-reported diarrhea information over the entire 14-day period. We also collect neighborhood level information, indicators of neighborhood level wealth, environmental soil and water samples for testing. We're collecting climate data. And then, of course, the geo-tracking of children and infants between households and these neighborhood settings is also connecting our household level data to our neighborhood level data. The telemetry piece of this is a particularly novel spatial exposure assessment approach that has not really been applied elsewhere. We're using just standard telemetry tools, geo-tracking tools that pet owners might use to check on their dog Toto while they're off at work for the day. But in putting these geo-trackers on children and infants, we can generate really in-depth maps like this that are showing children spending time in the household setting and then wandering out into public areas. We are collecting a lot of different types of infant, zoonotic, and environmental samples from these household and neighborhood settings and testing them for very similar pathogens that I've described previously for Safe Start, market to mouth, and social microbes. And this is sort of concluding piece here. All of this data is going to be integrated into new Bayesian multivariate social spatial temporal models, network models, and movement models. And ultimately, that is going to be used to inform a computational tool for building a virtual laboratory. It's still very early for us to talk about next steps, but some of the things that we're interested in doing is turning this into a longitudinal cohort where we can track these children for longer periods of time, and especially start integrating more in non-communicable disease type pieces of data that these children might not experience as much now, but might as they, as they become adolescents and their households gain in wealth. We're interested in climate data. We want to go back and look at the microbiome and the relationship of the microbiome to these exposures, and finally, antimicrobial resistance. So these are all sort of points that we want to follow up on with future grants. So with that, any questions?
Great, great. We'll do a virtual and real round of applause. Thank you. I was going to jump in a couple of places, but I wrote down my questions, but maybe we could have folks here that are much more into these topics than I see a lot of them here. Maybe you could jump in now and comments or questions for Kelly.
Thanks, Kelly. I was just going to mention, we actually have a really thriving microbiome program at Rutgers, which I don't know if you're aware of. And I'm only tangentially part of it. But one of the things that the group is doing, and I am part of, is establishing a new statewide birth cohort focused on the microbiome. So obviously it's a little bit, geographically separated from your interests, but I think to the extent that you're interested in the role that the early life microbiome plays in shaping children's health, this will be a really great environment to do that in.
That would be, yeah, that would be great. I mean, I didn't get a chance to mention this. We have a second NSF evolution and ecology of disease mechanism sort of currently pending, should hear about it any day, but it's actually focused on daycares in the United States. There's not a lot of data on enteric infections in children in high income environments. And so some of our pilot data from those daycares actually has revealed some level of transmission by these children. And so, absolutely, I think there's also a lot to be learned by comparing microbiome pathogen relationships for children in high income versus low income environments. For example, I mentioned the rotavirus vaccine, right, has really changed rotavirus sort of prevalence in high income countries recently. We see less protection from these rotavirus vaccines in children that are living in disease endemic environments. And I think that the microbiome is playing a big role in that. Yeah, thank you for that information.
If nobody has a question, can I jump in?
Please, yeah, step on.
Yeah, hi. Thank you, Dr. Baker. Very interesting. I was impressed by the 6 to 9 month change that you're describing in terms of frequency of pathogens in the kids. And you didn't mention breastfeeding. Is there a relationship to weaning at 6 months and then the transition into the immune-dependent response of the kids? Or is this a mobility issue? Are the kids crawling around more at 9 months than at 6 months? That would be question one. And the other question was about the household management of food hygiene. I was thinking if you take a clean milk and put it in a dirty plastic cup that has not been washed for a long time or is washed with dirty water, it doesn't matter in the end what you used to put it in, right? So how important is that aspect? Thank you.
Absolutely. So so starting with the sort of question about breastfeeding and what's going on 6 to 9 months. Definitely, 6 to 9 months is this critical. I mean, I know I'm probably preaching to the choir here, but it is this really critical developmental group of milestones that does relate to mobility. Based on what we have seen, I don't think that it is an issue so much of children all of a sudden spending more time outside the household. We see babies accompanying their mothers or their 13-year-old siblings from the first month of life. I do think it has a lot to do with caregivers putting those children down so that they can crawl and explore and move. Also, as children get older, mothers are more likely to trust the older siblings as caregivers. And so we do see, at least qualitatively, we do see children that are above 6 months of age being left with secondary caregivers more than children under 6 months. I I'm going to put quotations on that because our PATHOME data will reveal more about that. At this point, it's really just very small numbers of observations. On the breastfeeding point of this, so the trial that we have pending with NIH is actually in collaboration with the Ministry of Health in Kenya, as well as our longstanding Kenyan partners that have been involved in all these other studies. And what we're proposing to do is to test whether adaptation of Kenya's early childhood exclusive breastfeeding program to integrate more education and behavior change promotion about safe food preparation prior to 6 months of age can reduce disease in children. The reason why is that the statistics on breastfeeding in Kenya, as well as many other places, are grossly inflated. If we ask caregivers in surveys whether they are exclusively breastfeeding, they will say yes up until 6 months of age, and then we get kind of different answers. But if we go in and ask them to give us the 24-hour diet of what they've given their children, we only find about 58% of caregivers, this is from the Safe Start data, only about 58% said that they gave their child breast milk in the last 24 hours. And milk and porridge kind of fill in that gap with other types of food. So, a lot of breastfeeding is ending much earlier than 6 months. So our argument to NIH is that there are certain barriers that are inherently tied to gender norms and poverty and social norms that are going to preclude a certain subset of the population from ever being able to adhere to exclusive breastfeeding to 6 months of age, and that it is a disservice for public policy programs to withhold information about secondary coping behavior, like safe coping mechanisms, safe food preparation, until 6 months of age. So we have convinced the Ministry of Health to let us explore whether, with careful monitoring of breastfeeding, whether we can perhaps put a safety net under that group of households. And when they decide to stop breastfeeding, make sure that they're doing, that they're preparing food safely. On contamination of cups and other utensils, one of my colleagues has done a more in-depth study on plates and cups and other types of utensils. And he's definitely found lots of surface contamination of these food, cooking, and eating objects. We don't have the data to sort of link, the food coming into the household for food preparation and eating. I don't think we don't have enough data to sort of say the importance of those objects yet.
Thank you.
So Derek Schindel, you want to jump in?
Yeah, just coming unmuted. Thank you, Dr. Baker. Really interesting talk. Like Emily, I'm not really involved in the microbiome. I'm actually focused more on adolescents and adults, but certainly I'm a children's environmental health scientist. So the question I have for you is, is it possible, is there a future aspect of your work that might try to also focus on the hygiene and practices of adolescent siblings or even other family members that care for the young children who are using the products that you were focused on, especially the packaged milk? In particular, these products are also used at schools. I could see how multiple age groups would be potentially impacted if hygiene practices were a problem. And I think we all can agree hygiene came into focus again during COVID-19, especially early on. And as it should in many areas of public health.
Absolutely, yeah. So just starting off from the sort of US framework, the behavioral observation tools and environmental sampling that we do can be replicated anywhere. I mean, that's what the new NSF Evolution and Ecology of Infectious Disease grant would do, was expand these into the daycares here. And it could certainly happen in schools in the United States and elsewhere. Changing up the targets even. We don't have to necessarily look for enteric pathogens. We can also look for respiratory pathogens or other types of opportunistic organisms. In Kenya, we're very interested in adolescents because we found, sort of going back to one of the other responses I made about children being left with other caregivers after 6 months of age, only about a third of the 888 children we enrolled into Safe Start were cared for by their primary caregiver throughout the entire day. The other 2/3 of them had a wide range of secondary caregivers, often father or siblings, sometimes neighbors and grandmothers and aunts. So, in Safe Start, we only targeted food hygiene behaviors for the mother, and that was one of our lessons out of that, through the course of the study, is that you have to improve infant care behaviors for everybody involved. Studying adolescents as caregivers is sort of complicated, in part tied to human subjects, sort of research justification and capacity for even proposing an intervention that would tackle adolescents. But yes, we do suspect that adolescents play a big role in the exposure of their siblings, their younger siblings. Did I answer your question?
Yeah, I just muted myself again. Yes, you did. Thank you. And yeah, I think we all know how much work it takes to get the IRB approvals for all this. And so I commend you for what you're doing. I think Emily and Stefan, I have our stories too, but I think you're doing really interesting work. And as you expand, look forward to seeing what you do in the journals.
Arpita Jindani.
Thank you, Dr. Baker. Great presentation. I really enjoyed it. And I was nodding the whole time when you were talking about MBOVIS, MTB. I'm sure Dr. Gennaro was as well. We've seen that in the past at my role at Global Tuberculosis Institute, patients coming in with that exposure. I actually was, as you kept talking through different pieces, I kept noticing that there are so many opportunities for behavior change intervention, as a result of your work in terms of whether it's micronutrient supplementation or if it's related to, food hygiene related behaviors. And I'm wondering, as an add-on to your work, have you partnered with any community organizations, to sort of bring about, how have you gone about bringing change to the community through community partnerships? It would be interesting to hear that. Thank you.
Right, and actually I sort of rushed through and didn't touch on my last slide, but none of this work would be implementable without my partners in Kenya. So I collaborate with a institute called the African Population and Health Sciences Center, APHRC. They specialize actually in translational science and policy change. So they're a really nice match to some of the statistical and exposure assessment approaches that I and Dan Sewell, who's the co-PI on PATHOME, they're a great pair for us. And so they are really the sort of partners that help us gain community input on the design of the studies, the interpretation of those studies, the translation of those studies into policy. They're wonderful partners.
Thank
Great.
you.
Thank you. We're at the top of the hour. Any last comments, Kelly or anybody? Yeah, Gloria.
It's Gloria. I just wanted to mention that along these lines, and Emily already spoke about the New Jersey Kids study. We are going to be the first state to have the One Health Task Force, which is going to be looking at all these issues, and it has been legislated, and so we're very happy about that as well.
Well, that's great.
Yeah.
So I have a quiz for the TB people. There's Marilla had to jump off. Sorry, but Stefan's still here. And so there's one state in the union that has the highest rate of Mycobacterium bovis in humans. It's the same state that is the only state that doesn't require pasteurization of milk.
New Mexico?
Sorry, I'm inherently biased. So, but thank you, Kelly. This has been fantastic. I'll have to ask you my questions out of ignorance, but offline when we talk again. Thank you, everybody, for attending. It was fantastic. I think we all learned a lot.
Good. Well, it was my pleasure.
Great. All right.
Thank you all.
Bye-bye.
Have a good afternoon.
Thank you.
Cheers.